Discuss the classification, etiology, clinical features, investigations, and management of malnutrition. PEM, protein energy malnutrition or undernutrition. This question can be asked as causes of weight loss. BMI less than 18.5 is called malnutrition or undernutrition. Classification: BMI 17 to 18.5 is mild, 16 to 17 is moderate, less than 16 is severe. Etiology of undernutrition and weight loss: famine, endocrine disorders such as hyperthyroidism, pheochromocytoma, adrenal insufficiency, uncontrolled diabetes mellitus, GI disorders, malabsorption syndrome, chronic pancreatitis, IBD, parasitic infestation, malignancy. Infections: tuberculosis, HIV, subacute bacterial endocarditis, COPD, chronic renal failure, psychiatric disorders, depression, mania, anorexia nervosa, schizophrenia, chronic alcoholism, drugs, opiates, amphetamines, digoxin, metformin, NSAIDs, anti-cancer drugs, treatment of obesity, anorexic drugs, amphetamines and derivatives, distance runners, models, ballet dancers, gymnasts, excessive physical activity, example, marathon runners. Clinical features: in children, undernutrition, that is protein energy malnutrition, PEM, is manifest as the syndrome of Kwashiorkor, malnutrition with edema, and marasmus, malnutrition with marked muscle wasting. The clinical features of severe undernutrition in adults are as follows: weakness, apathy, loss of initiative, depression, introversion, thirst, craving for food, weight loss, muscle wasting, loss of subcutaneous fat, amenorrhea or impotence, pale dry skin with loss of turgor, hair thinning or loss, cold and cyanosed extremities, pressure sores, edema which may be present without hypoalbuminemia, subnormal body temperature, slow pulse, low blood pressure, distended abdomen with diarrhea, diminished tendon jerks, susceptibility to infections such as gastroenteritis, tuberculosis, skin infections, etc. In advanced starvation, patients become completely inactive and may assume a flexed fetal position. In the last stage of starvation, death comes quietly and often quite suddenly. All organs are atrophied at necropsy except the brain. Investigations: mild anemia, leukopenia, thrombocytopenia. ESR is normal unless there is infection. Low blood glucose, plasma free fatty acids are increased and there is ketosis and mild metabolic acidosis because of breakdown of fat for energy production. Albumin may be low but concentration is often normal because of normal liver function. Insulin secretion is low. Glucagon and cortisol secretion is high. Urine has a specific gravity and creatinine excretion becomes low. Tests of delayed skin hypersensitivity, example tuberculin, are falsely negative. ECG shows sinus bradycardia and low voltage. Management: people with mild malnutrition do not require any active treatment. Those with moderate malnutrition need extra feeding. Severe malnutrition needs hospital care. In severe malnutrition, initial efforts should be directed at correcting fluid and electrolyte abnormalities and infections. The second phase of treatment is directed at repletion of protein, carbohydrates, and micronutrients. In severe malnutrition, there is atrophy of intestinal epithelium and of exocrine pancreas, and the bile is dilute. Hence, refeeding should be initiated with small amounts of food which is easily digestible. Food should be palatable and similar to the usual staple meal. For example, a cereal with some sugar, milk powder, and oil. Either the enteral or parenteral route can be used, although the former is better. About 1500 to 2000 kilocalories per day will prevent progressive undernutrition, but additional calories are required to regain weight. A weight gain of 5% body weight per month is satisfactory. Patients should be followed up closely.